Welcome to Weekly Neurology Deep Dive, produced by America Vanini.
It is great to be here to unpack this.
Just a quick note up front for everyone listening. This audio is strictly for educational purposes. It has no commercial goals, and it serves only as a summary. We highly recommend that you read the full paper we are discussing today to capture every single clinical nuance.
Absolutely. The primary paper is essential reading.
Today, we are analyzing the European Stroke Organization, European Association of Neurosurgical Societies, and European Society for Minimally Invasive Neurological Therapy Guideline on Aneurysmal Subarachnoid Haemorrhage.
That is quite a title, but it is a monumental paper.
It is. This paper was led by corresponding author Mervyn Vergoen and published in May 2026 in the European Stroke Journal. We have a remarkably dense set of recommendations to cover today.
We really do. There's a lot of ground to cover.
But before we begin exploring the specific data and, the mechanisms behind these guidelines, could you provide a rapid, practical summary for the neurologists listening who might be short on time?
I can certainly do that. So when managing aneurysmal subarachnoid hemorrhage, do not use antifibrinolytic drugs routinely, but do administer oral nimodipine.
Understood.
Furthermore, you should secure the ruptured aneurysm within 24 hours, preferably with regular coiling if the patient is in good clinical condition.
And regarding the facility?
Yes. Base your treatment decisions on a multidisciplinary discussion between a neurosurgeon and a neurointerventionalist, ideally in a center treating at least 70 of these cases per year.
Excellent. We will repeat that practical summary at the end of the show to ensure those takeaways are totally cemented for you.
It is always good to reinforce the main points.
So let us start directly at the bedside. We are looking at those immediate medical decisions required when a patient first presents to the hospital well before the aneurysm is definitively secured.
The initial hours are incredibly tense.
They are. The initial instinct for any neurologist faced with a ruptured aneurysm is, of course, to halt the bleeding process entirely.
That is the natural reflex, exactly.
However, the paper delivers a strong recommendation against the routine administration of antifibrinolytic drugs prior to treatment, which often surprises people.
It does.
Yeah.
Let us unpack that antifibrinolytic paradox I mentioned in the introduction, because the data indicate these drugs significantly reduce the risk of a catastrophic rebleed, correct?
They do. They significantly reduce rebleeding.
So why does preventing a secondary hemorrhage not translate to better functional outcomes for the patient?
That paradox is basically the central tension in the acute management phase. The pooled analyses in the paper confirm that antifibrinolytics significantly reduce the risk of rebleeding.
Which sounds like a massive win.
It does. If we're only looking at the anatomy in the initial vessel, these drugs look like a total success.
But we treat patients, not just vessels.
Exactly. When we look at the metrics that actually matter most to the patient's life, that anatomical benefit completely disappears. How so?
The data show that antifibrinolytic administration does not decrease the risk of poor functional outcome. It lands at an odds ratio of about 1, which is not significant.
That is striking.
It is. Furthermore, it does not decrease case fatality. That also shows an odds ratio of about 1. Again, not significant.
So we are fixing the stand, but we are not fixing the patient.
That's precisely. The explanation for this paradox is that the reduction in rebleeding is entirely offset by a simultaneous increased risk of delayed cerebral ischemia.
Oh, I see.
Yes. By administering a systemic drug to stabilize the clot at the rupture site, you are inherently promoting a prothrombotic state everywhere else.
Which is the last thing an injured brain needs.
Exactly. The drugs prevent one devastating complication only to promote another by worsening microvascular ischemia elsewhere in the brain. So the overall functional trajectory for the patient remains completely unchanged.
That significantly alters the risk-to-benefit calculus. I mean, you must look at the downstream consequences, not just the immediate anatomical fix.
You really must.
This brings us to another critical acute parameter, blood pressure.
A very hot topic.
Very hot. The patient is in the emergency department, the blood pressure is elevated, and the natural reflex might be to drop it aggressively to protect the aneurysm. How does the expert consensus guide blood pressure management in these initial volatile hours?
Well, blood pressure management requires a highly delicate balance.
I can imagine.
The consensus suggests that for systolic blood pressures persisting above 160 to 180 millimeters of mercury, despite the administration of analgesics and nimodipine, physicians should consider lowering the systolic pressure.
Down to what target?
Down to about 160 millimeters of mercury. The ultimate goal is to reduce the rebleeding risk, but the exact method of reduction is paramount here.
Meaning the speed at which you lower it.
Yes, this reduction must be performed slowly and in a highly controlled manner using short-acting medications.
Because I imagine the danger there is the physiological undershoot. If a physician uses a long-acting antihypertensive and the pressure just plummets, they have severely compromised the patient.
That is the exact danger. You must avoid any undershoot because a sudden precipitous drop in mean arterial pressure can severely compromise cerebral perfusion.
Especially in an injured brain.
Right. Exactly. In a brain that has just suffered a subarachnoid hemorrhage, normal autoregulation is frequently impaired.
So the brain cannot compensate for the drop in pressure.
Correct. If you aggressively drop the systemic pressure, you can instantly starve the vulnerable ischemic penumbra of blood flow.
And trigger delayed cerebral ischemia.
Exactly. You trigger the very delayed cerebral ischemia we are actively trying to prevent. Short-acting medications give you the physiological breaks necessary to stop the reduction exactly at the target.
Speaking of delayed cerebral ischemia, it is one of the primary drivers of poor outcomes and mortality in this population.
It is the main enemy in the intensive care unit.
It really is. It is the complication we are constantly anticipating. What does the paper establish regarding pharmacological prophylaxis to prevent it?
The evidence here is robust and definitive. It draws a very clear line between what works and what simply does not work.
Let us hear it.
There is a strong recommendation for the prophylactic use of oral nimodipine to decrease the risk of poor functional outcome.
So oral nimodipine is the gold standard.
Absolutely. Conversely, there's a strong recommendation against the use of tyrolizide, statins, magnesium sulfate, and endothelin receptor antagonists.
I want to pause on that list of failed interventions for a second.
It is a long list.
It is. Neurologists have spent decades theorizing about magnesium protocols or statins for neuroprotection. Why do these highly logical theories fail so dramatically in the actual clinical data?
It essentially comes down to the ruthless reality of clinical trials versus physiological theory.
The theory always looks perfect on a whiteboard.
Exactly. Theory suggested that magnesium might provide neural protection through calcium channel blockade, or that statins might reduce neuroinflammation and improve endothelial function.
And endothelin receptor antagonists logically should reverse vasospasm.
They should. Yet none of these have demonstrated a significant benefit in improving functional outcomes in the pooled data.
Fascinating. So why do they fail?
Well, sometimes the systemic side effects, such as hypotension from magnesium, completely negate the localized cerebral benefits.
That makes sense.
Other times, reversing the angiographic vasospasm simply does not reverse the complex cellular cascade of delayed cerebral ischemia. Spasm is only one part of a much larger ischemic problem.
I see. Are there any other therapies we should avoid for prophylaxis?
Yes, the paper notes that no recommendation can be made for prophylactic antiplatelets or lumbar drainage to prevent delayed cerebral ischemia.
Just a lack of data.
Completely insufficient data from randomized trials. So nimodipine stands completely alone as the proven prophylactic standard of care.
Understood. So the patient is stabilized, oral nimodipine is on board, and the blood pressure is controlled around 160 millimeters of mercury.
The acute medical phase is managed.
Yes. Now we must address the underlying structural problem and secure the ruptured aneurysm.
The critical procedural step.
Timing is obviously a massive variable here. The instinct is to rush them to the suite immediately. What is the optimal window according to the guidelines?
The expert consensus suggests treating the ruptured aneurysm within 24 hours after the ictus.
24 hours.
However, there is a massive and critical caveat attached to this 24-hour window. This should be done provided the most dedicated team of experts is available.
I want to challenge that 24-hour window a bit.
Go ahead.
For a ticking time bomb, 24 hours can feel dangerously slow for a ruptured aneurysm. Why not mandate treatment within 3 hours or 6 hours, just like we do with intravenous thrombolysis in ischemic stroke?
Because securing an aneurysm is not simply pushing a drug through an intravenous line, it is an incredibly complex, high-risk physical procedure.
A procedural challenge requires a different framework.
Exactly. The urgency to secure the aneurysm must be balanced against the necessity of having the most experienced personnel performing the intervention.
You want the best hands on the catheter.
Always. A tired, less experienced on-call team operating at 2 in the morning carries a significantly higher procedural risk than the dedicated, specialized neurovascular team operating at 8 in the morning.
That makes perfect sense.
The guidelines reflect the reality that human performance and team cohesion matter just as much as chronological speed.
Let us examine the selection of the procedure itself, assuming that specialized team is assembled.
Okay.
We have a patient in good clinical condition, explicitly defined by the paper as World Federation of Neurosurgical Societies, stages 1 to 3. And their aneurysm is morphologically suitable for either regular coiling or microsurgical clipping.
A classic scenario.
What is the recommendation?
The guidelines strongly recommend regular coiling.
Regular coiling feels like, the trusty standard workhorse vehicle. It is proven, it is reliable, and we have mountains of long-term data on it.
It is the workhorse for a reason.
But in the modern neurointerventional suite, we also have access to incredibly advanced devices. We have flow-diverting stents, intrasaccular devices, and stent-assisted coiling.
The sports cars, so to speak.
Exactly, the sports cars. Why does the guideline tell us to leave the newest technology on the shelf during an acute hemorrhagic crisis?
The reason we rely on that workhorse vehicle in the acute setting is grounded strictly in the evidence of patient safety.
The newer devices are not safe acutely.
Well, there are no high-quality data supporting the use of devices like stent-assisted coiling or flow-diverting stents for decreasing poor outcomes compared to regular coiling.
And there are risks with the new tech.
Yes, we have to consider the pharmacological requirements of these newer devices. They often require the immediate initiation of dual antiplatelet therapy to prevent in-a-stent thrombosis.
And introducing massive doses of antiplatelets into a patient who has literally just bled into their subarachnoid space sounds like a recipe for disaster.
It introduces a massive hemorrhagic risk.
I can only imagine.
This patient has a freshly ruptured aneurysm, irritated meninges, and they may require immediate further interventions. For example, the placement of an external ventricular drain for hydrocephalus.
Oh, absolutely.
If you have loaded them with dual antiplatelets for a stent, that subsequent surgical drain placement becomes incredibly dangerous.
You have essentially backed yourself into a pharmacological corner.
Precisely. Therefore, the paper stresses that these advanced devices should be reserved strictly for selected cases, or utilized exclusively as last-line treatments when regular coiling is anatomically not feasible.
So we are intentionally trading the allure of anatomical perfection for physiological safety in the acute phase.
That is the perfect way to summarize it.
Does that mean every single patient gets regular coiling? Or are there specific subpopulations where the standard recommendation shifts?
There are two notable exceptions highlighted in the consensus statements where the approach fundamentally changes.
Let us go through them. What is the first exception?
First, for patients under 45 years of age, the multidisciplinary team should strongly consider microsurgical clipping rather than coiling.
Why the distinction for the under 45 population? Is it purely a matter of durability?
Exactly. It is all about the years of life ahead. The rationale is that microsurgical clipping provides significantly better long-term protection against aneurysm recurrence.
Because it's a mechanical clamp on the outside of the vessel.
Correct. When you place a physical titanium clip across the neck of the aneurysm, it is generally a definitive, lifelong cure.
And coiling is not always lifelong.
Coiling, while less invasive, has a known rate of recanalization over time.
I see.
For a 40-year-old patient who has decades of life expectancy remaining, the statistical risk of that aneurysm reopening over the next 30 years is a major factor.
So the durability of clipping outweighs the invasive nature of the craniotomy in this specific young demographic.
Absolutely. It is a trade-off that favors clipping for the young.
What is the second exception?
The second exception is for patients presenting in a coma with a space-occupying intracerebral or subdural hematoma.
A much more dire presentation.
Extremely dire. In this scenario, the suggested approach is immediate open surgery for both the clipping of the aneurysm and the physical removal of the hematoma.
Because you have to manage the intracranial pressure.
Exactly. You cannot resolve the lethal mass effect of a large hematoma from inside the blood vessel with a catheter. You must relieve the pressure physically.
Understood. Let us move forward in the timeline. We have secured the aneurysm. The patient now moves to the intensive care unit.
The monitoring phase begins.
Yes. And this phase is characterized by intense hour-by-hour vigilance for any signs of clinical deterioration. If a patient does neurologically decline, the first question is always whether it is rebleeding, hydrocephalus, or delayed cerebral ischemia.
The differential diagnosis of deterioration.
Exactly. How does the paper suggest we investigate that decline?
The suggested first step for evaluating any clinical deterioration is a plain head CT combined with CT perfusion imaging.
Not an MRI.
No, CT is preferred here because it is incredibly efficient. The non-contrast CT allows you to immediately identify structural causes.
Like the development of new hydrocephalus or a catastrophic rebleed.
Correct. And simultaneously, the perfusion scan helps detect areas of critically reduced cerebral blood flow.
Which points to delayed cerebral ischemia.
Exactly. It points directly to evolving delayed cerebral ischemia before it becomes an irreversible infarction.
I am looking at the section on neuromonitoring, and I have to say, the recommendations seem to run counter to modern intensive care unit culture.
They do challenge the status quo.
There is a pervasive philosophy in critical care that more data is always better. Let us place more probes, gather more numbers, and monitor every single physiological parameter.
The drive for continuous data.
Yes, yet the paper suggests against routine invasive neuromonitoring. Specifically, it suggests against the continuous measurement of partial pressure of brain tissue, oxygen, and microdialysis.
And EEG as
Yeah.
well.
Right, I mean, absolutely. It also suggests against routine continuous EEG. Why are these guidelines telling neurologists to intentionally look at fewer data streams?
It is a profound shift in perspective. The instinct is certainly to monitor everything possible, assuming more information automatically leads to better decisions.
It feels safer to have the numbers.
It does. However, the expert panel concluded that the risk-to-benefit ratio for these invasive and complex monitoring systems remains highly uncertain.
Because the probes themselves carry risk.
Absolutely. Placing invasive oxygen probes or microdialysis catheters carries inherent risks of creating new hemorrhages or introducing central nervous system infections.
And what about the data itself? Is the problem that we do not actually know what to do with the numbers once we have them?
That is the core issue. Complex monitoring systems generate a vast continuous amount of data, but that data frequently lacks clear, evidence-based treatment thresholds.
So you have the number, but no instruction manual.
Exactly. If the brain tissue oxygen drops by a marginal amount, does the physician intervene? With what therapy?
It could lead to a lot of unnecessary treatments.
It severely overcomplicates clinical decision-making. It can lead to reactive interventions that do not ultimately improve functional outcomes for the patient.
So the paper is saying do not use them routinely.
The paper's stance is definitive. Until there is clear evidence that managing patients based on these specific continuous parameters actually improves their functional outcome, they should not be used routinely.
I see. So we rely on our clinical assessment and targeted imaging instead.
Correct.
If that CT perfusion scan and the clinical exam confirm that delayed cerebral ischemia is indeed unfolding, we enter a critical rescue phase. The oral nimodipine is obviously not enough at this point.
Now we have to escalate.
The paper outlines a specific escalation ladder for treatment. Walk us through that progression.
The progression is methodical. If delayed cerebral ischemia occurs and standard fluid therapy proves insufficient to maintain cerebral perfusion, the first suggested intervention is induced hypertension.
Induced hypertension. This is where we pharmacologically drive the systemic blood pressure up to literally force blood past the spastic, narrowed vessels in the brain.
Precisely. You are using systemic pressure to overcome the increased cerebrovascular resistance.
Are there any prerequisites for this?
Yes, the guideline includes a vital prerequisite. You can only induce hypertension provided the aneurysm has been definitively secured.
That makes sense. You cannot drive up the pressure if the rupture site is still unprotected. You would just cause another massive bleed.
Exactly. The aneurysm must be secured first.
What if induced hypertension fails? The patient continues to decline, the perfusion scan worsens, and they demonstrate severe refractory vasospasm. What is the next step on the ladder?
If hypertension fails, intra-arterial pharmacological treatments can be considered as a rescue therapy.
Going directly to the source.
Yes. This involves the neurointerventionalist navigating a catheter directly into the cerebral vasculature and infusing vasodilators locally into the spasming vessels.
And what about mechanical vasodilation? Specifically using a balloon angioplasty to physically stretch the spastic blood vessel back open.
The guidelines are extremely cautious regarding mechanical vasodilation.
Really?
Yes. Balloon angioplasty is classified strictly as a last-line rescue option. The data are simply insufficient to support its routine use.
Why is it pushed so far down the algorithm?
The expert consensus insists it should only be considered after a careful multidisciplinary discussion. You're weighing incredibly high procedural risks against uncertain benefits.
Because physically stretching a spastic, inflamed cerebral vessel with a balloon carries a massive risk of simply rupturing the vessel entirely.
Exactly. It is a desperate measure for a desperate clinical scenario.
We must also address hydrocephalus. It is a frequent, persistent complication in the intensive care unit, as the subarachnoid blood blocks the reabsorption of cerebrospinal fluid.
A very common issue we face.
For a patient who develops communicating hydrocephalus and begins to exhibit a decreased level of consciousness, what is the primary suggested strategy?
For that specific clinical scenario of communicating hydrocephalus, the primary suggested strategies for cerebrospinal fluid diversion are either the placement of a lumbar drain or performing repeated lumbar punctures to relieve the pressure.
Understood. Let us zoom out from the individual patient bed for a moment. We should look at the broader systemic requirements necessary to deliver this highly complex level of care.
The macroscopic view.
Yes. We have talked about specialized neurointerventionalists, multidisciplinary teams, and advanced imaging. The paper does not just give medical advice, it details highly specific volume metrics for facilities and operators. What are the numerical thresholds required for optimal care?
The guidelines are unambiguous regarding system requirements, and they are quite strict.
Give us the numbers.
Patients should be admitted to a dedicated neurointensive care unit in a center that treats at least 70 patients with aneurysmal subarachnoid hemorrhage per year.
70 per year.
Yes. Now, in geographically remote areas where populations are sparse, this threshold is adjusted to at least 35 patients per year.
And what about the individual surgeons?
Furthermore, the individual treating physician, whether a neurosurgeon or a neurointerventionalist, should perform the chosen procedure on more than 30 aneurysms per year.
Those numbers demand serious structural reflection for hospital administrators and health policymakers.
They really do. It requires reorganization.
This specific guidance essentially dictates that health systems must heavily centralize stroke care. I mean, a small community hospital simply will not hit 70 aneurysmal subarachnoid hemorrhages a year.
No, they will not.
Nor will their on-call surgeon clip 30 aneurysms a year. This requires a strict hub-and-spoke model to ensure you have the right specialized high-volume teams available.
Exactly.
If a patient arrives at a spoke hospital, they must be rapidly transferred to the hub. And the paper explicitly mandates a multidisciplinary approach for every single patient at that hub, correct?
Exactly. Every single patient must be discussed by a multidisciplinary team containing at least one neurosurgeon and one neurointerventionalist.
To avoid bias.
Correct. This ensures that the decision between microsurgical clipping, regular coiling, or alternative endovascular options is totally balanced. It prevents specialty bias.
You want the team to choose the best tool, not just the tool they happen to know best.
That is the whole point.
Yeah.
The goal is a treatment plan tailored to the safest and most durable outcome for that specific aneurysm morphology and that specific patient's clinical status.
Finally, we must discuss long-term surveillance. The patient survives the catastrophic acute rupture, they navigate the intensive care unit stay without succumbing to delayed cerebral ischemia, and they are eventually discharged to rehabilitation.
A massive success.
It is, but the story does not end there. What does the radiological follow-up schedule look like to ensure that aneurysm stays secured?
The timeline for surveillance depends entirely on the initial treatment modality and the patient's underlying physiological risk factors.
Okay, let us break that down.
If a patient is treated with regular coils and their imaging shows adequate occlusion of the aneurysm at 6 months, the consensus suggests only one additional follow-up scan at or beyond 12 months.
So if it looks solid at a year, you can essentially stop scanning them?
Generally, yes.
What if it does not look solid?
However, if there are neck remnants or the aneurysm is only partially occluded, follow-up imaging beyond 6 months is absolutely required to monitor for regrowth.
What about the newer devices?
Now, if the aneurysm was treated with newer devices, such as flow-diverting stents or intrasaccular devices, the timeline changes. Because we have less long-term data on these technologies, radiological follow-up is necessary out to at least 5 years.
We discussed earlier that younger patients might get clips because they have decades to live. Are there specific populations that require indefinite, lifelong screening because their underlying biology predisposes them to forming completely new aneurysms?
Yes, there are. High-risk patients require screening every 5 years for the development of de novo aneurysms.
De novo meaning totally new ones.
Exactly. This is not checking the old aneurysm. This is checking for entirely new ones.
Who falls into that high-risk category?
This high-risk category includes patients with a young age at initial presentation, patients with a documented positive family history for aneurysmal subarachnoid hemorrhage, or patients carrying a diagnosis of autosomal dominant polycystic kidney disease.
Which has a well-known genetic association with vascular fragility.
Yes.
We have
Absolutely.
covered the entire clinical trajectory from the emergency department doors to the 5-year follow-up clinic.
It is a vast amount of information.
It is, to ensure the key takeaways are crystal clear for daily clinical practice. Could you repeat the practical summary exactly as you delivered it at the start of our discussion?
Certainly. When managing aneurysmal subarachnoid hemorrhage, do not use antifibrinolytic drugs routinely, but do administer oral nimodipine. Secure the ruptured aneurysm within 24 hours, preferably with regular coiling if the patient is in good clinical condition. Base treatment decisions on a multidisciplinary discussion between a neurosurgeon and a neurointerventionalist, ideally in a center treating at least 70 of these cases per year.
Perfect. Before we wrap up, I want to leave you with a final provocative thought drawn directly from the discussion section of the paper.
Go ahead.
We established earlier that delayed cerebral ischemia is a primary driver of the about 40% fatality rate associated with this disease.
Staggering number.
Yeah, as we move through the guidelines for induced hypertension, intra-arterial pharmacological treatments, and balloon angioplasty, the recommendations were consistently labeled as suggested or considered as last line due to a lack of high-quality data.
That is the unfortunate reality.
It reveals a glaring, almost frightening lack of high-level evidence for managing the very complication that kills so many of these patients.
It really highlights a gap in our knowledge.
It underscores an urgent, critical need for the neurology and neurocritical care communities to design and conduct robust randomized trials for rescue therapies. Until we have that data, we are essentially fighting our most lethal enemy in the dark.
A very sobering point to end on.
Thank you for joining us on this edition of Weekly Neurology Deep Dive. We will see you next time.